in a very interesting and very necessary field of science, urology, and we are very happy that we have very nice and important professors during this meeting. And I wish you all participants, a very nice time with us, and I hope that you will like our courses too.
Thank you, Christina. So with this, it is my honor to introduce our first lecturer, Professor Jalesh. Professor Jalesh is the professor of neurology at the University College of London, and he is also the clinical lead at the National Hospital for Neurology and Neurosurgery, Queen Square, London. So he has very good number of publication, and his expertise in neurogenic lower urinary tract symptoms and the pelvic neurophysiology. So with this strong, so I think it will be a very great foundation for our course. So Professor Jalesh, I want to give you the floor. So it is now your floor. We are ready to learn. So I wish every participants to have this very good learning experience. Professor, floor is yours. Thank you.
Brilliant. Well, thank you very much. And good afternoon or good evening. I'm not sure why the emojis keep coming up on my screen. I can assure you it's not me applauding myself. It's somehow, I think, Teams doing some sort of emoji. But essentially, it's a great pleasure to be here. So Ruth Kirshner-Herman, who you can see, and Ruth and myself have been working together with Abhinav and his team to actually formulate this. Just a bit of a bit of an introduction, actually, is that when MedSynergy approached INUS more than a year ago to invite a couple of lectures, we were intrigued because medical students showing an interest in something as specialized as neurourology was something that was a request that usually doesn't come into our mailbox. But we had a couple of speakers last year, and it was their more general conference. And the feedback we had was great, and apparently MedSynergy loved the idea. And hence the idea of having a lecture series was born towards the end of the year. Ruth will during the course of this lecture series will explain her links with the Ukraine and the work she's doing in trying to develop neurourology, or even something even more basic in terms of functional urology and neurodynamics in the Ukraine. Then we came together and on the platform of INUS, the International Neuro Urology Society, thought it would be a good idea to actually see whether it's feasible to actually run a series of lectures. Now, this is sort of I would say we're all sort of part of this experiment because it's never really been done before to have a lecture series like this, that too in the summer. But if we find that this is that we have a receptive group, this is actually a program that could be rolled out in regions around the world where neurourology is underserved. And so we're quite interested to see how this pans out. The first of these 6 lectures is on the neural controls of bladder and sexual functions in health. Those of you who have seen the program would recognize stalwarts in the field of neurourology. Helmut Madesbacher, who's a doyen in the field, might be in the audience already or will be joining us this afternoon as well. But you'll be hearing essentially from lecturers from across the world who practice neurourology. Just a little bit about the International Neuro Urology Society. We have just crossed our 10th anniversary this year, and we're a not-for-profit organization really interested in promotion of neurourology, and this is why the principles of this lecture series actually aligns quite well with our objectives. We have a membership across four continents, from 44 countries, and in addition to raising awareness about bladder, bowel, sexual dysfunction following neurological injury, the aims of the organization is to improve evidence-based knowledge through collaborative research, improving medical care, and promoting networking and an opportunity to interact amongst healthcare professionals and knowledge transfer. What we find quite unique about this venture in particular is that MedSynergy represents medical students, but also has links with the European Medical Students Association, or EMSA, which means that we're actually having a group of young health group of young people who will become doctors in the future, and we're planting the seed of neurourology at such a tender period of their formative years of medical school, which we hope will then translate into more specialists coming into the field. Now, those of you who are under 36, and sadly I don't belong to this group, can actually register for free. And this is the QR code that you can join. And there's an email address there that you could reach out to our secretary, who will be more than happy to take you through the organization. But there's also a website. If you just Google INUS, you'll get to it. Just to let you know, we do run an annual congress, and this year it was in Zermatt. Next year in January, it's in this beautiful part of the world in Indonesia called Yogyakarta, and these were the topics that were covered last year. You can see it's very multidisciplinary in terms of the topics and the speakers that we bring, covering from the neuroscience to the practical applications to specific situations such as pregnancy, upper urinary tract risk, UTIs, many of which overlap with other fields of medicine and surgical practice as well. So on that note, I will dive straight into the topic today on the neural control of lower urinary tract and health. And this is sort of a double act, because I'll be spread over 2 weeks, of course. I'll be starting out with the neural control and health, and Helmut Madesbacher will take it forward, explaining what happens in neurological disease. And the learning outcomes from this session is to understand the neural control of the lower urinary tract and health, and to have just the initial glimpse of what happens following neurological disease. So for this, we need to take a step back. And because you are medical students, you will probably be more familiar with this figure. Essentially, it's that of the efferent autonomic innervation. And you would be familiar with the sympathetic and the parasympathetic limbs. The time doesn't permit to go into the neural control of the autonomic system, but essentially to understand that you have efferent sympathetic innervation that is illustrated in red, arising from the thoracolumbar segments, and we call this as the thoracolumbar outflow, and that's in red. And you have the parasympathetic outflow in blue that emerges from the nervous system in two regions. One is the brainstem through these cranial nerves, that's 3, 7, 9, and 10, as you can see here, and at the sacral cord at S2, 3, 4 segments. And so if you now view bladder, bowel, and sexual dysfunction as just a continuum of the innervation to the autonomic nervous system, you'll then understand that there's a shared peripheral innervation between these different visceral systems. And so when you have a neurological patient who presents with bladder, bowel, sexual dysfunction, it is likely that they will have other elements of autonomic dysfunction affecting their cardiovascular, pseudomotor, pupillary as well, depending on the type of neurological disease they have. Likewise, if you see a patient in clinic who has cardiovascular failure, for example, autonomic failure, it is likely that they will also have bladder and bowel sexual dysfunction, just because that shared peripheral innervation is damaged in their underlying neurological disease. Now, what this means is that there's also an overlap in central regulation as well, and therefore the dysfunction is shared. Now, amongst these different visceral systems, it's important to understand the uniqueness of the lower urinary tract. And one is the high dependence on the central nervous system. And this affords an element of voluntary control on the bladder, which is much more pronounced with the visceral systems of the bladder, bowel, and sexual organs compared to, say, blood pressure, heart rate, which we have, particularly with humans and other mammals, actually have less of a voluntary control over. Now, this means that this voluntary control has to be learned, and this learning process occurs in childhood. And so if there is a childhood insult, it could be, for example, maybe hypoxic brain injury at birth. It could be a trauma as a child, maybe a spinal injury, or it could be physical trauma. It could be sexual trauma. But if the functions are not learned, what happens is you get dysfunctional bladder and bowel, which then often then continue into adolescence and adulthood. And as an adult physician, we see these patients, and it's so important to go back into their past history to see if the dysfunction that we're seeing at that particular point of time in an adult clinic actually started in childhood. From a more biological perspective, there are differences in terms of neural activity. You have the tonic activity of the cardiovascular system. There's a second by second regulation of blood pressure and heart rate, whereas with the lower urinary tract, it's more of a phasic between a storage and avoiding phase. Now, in health, when you think about micturition control, it's once again, it's useful to think about this in the more general context of a goal-oriented behavior. So I'm sure most of you, knowing that this is the top lecture on the bladder, would have gone for a wee just before this lecture, and we therefore assume that your bladders are empty, and if you have a bladder in health, you're probably not feeling any sensations. Now, as this lecture proceeds, and maybe you have a cup of tea with you, you're drinking away, and you begin to feel that first sensation of needing to pee. Now, at this time, it's a sensation that you can comfortably and safely ignore whilst you listen to this lecture. But it does get you thinking about the bladder, and it's a phase in goal-oriented behavior of initiation and imagination of what would happen. Sorry, these emojis are not mine, so I don't know, it's some AI-derived tool, but some sort of a initiation and imagination that occurs about the toilet, which you can conveniently leave it as an imagination, and you don't need to act out. Now, what happens as the lecture proceeds, and if you're drinking a few cups of coffee, is that you then get a first desire of needing to pee, which you are not able to ignore, but you're still able to sort of put to the side and possibly even continuing to give your attention to this lecture. Now, this moves into the stage of exploring and foraging, what you would do as a goal-oriented behavior, and you start exploring, what would I do if I need to go to the toilet? Would I switch off my video? Would I mute myself? Is the toilet next door? You start thinking about it. But then you reach a stage of strong desire where it's time to pee. Your bladder is full, and so what happens is then you go to the toilet and you attain that goal of emptying the bladder, you void, and you reach a stage of attainment and satiation. Now, the phasic activity that I mentioned to you earlier suits the functions of the lower urinary tract well. And if you think about it in health, most of us, if we're healthy subjects, we're in a storage phase of the bladder, which is essentially a low pressure collection of urine in the bladder, which is happening during this phase. And then intermittently, when based on your volition, then there's a switch from the storage to the voiding phase when there's a voluntary periodic expulsion of the contents of the bladder through the urethra. Now, there are two important players, muscles that are involved in this process. One is the detrusor, and the other is the sphincter, and you'll be hearing these terms throughout the course of these 6 weeks. And the storage phase, the detrusor muscle is relaxed, allowing for that low pressure collection of the urine in the bladder. The sphincter muscles of the outlet are contracted and active to contain the urine and prevent leakage of urine. Now, the converse occurs in the voiding phase, during which when the detrusor muscle is actively contracting and eliminating the urine, and the sphincter muscles are relaxed and allowing for the urine to pass. Now, you'll be hearing today about the switch between storage and voiding phase, which is essentially at the level of your brainstem, in particular the pons, what we call the pontine micturition center, but other regions, particularly the periaqueductal gray, which I'll be explaining to you, play a key role in that switching mechanism as well. And in health, your bladder is in the storage phase around 99% of the time. It's only around less than 1% when the switch occurs and voiding happens. Now, when we think about the innervation, we think about the peripheral innervation. And it's important to understand that you need to have, therefore, the autonomic and the voluntary control of the lower urinary tract. And that's what makes the peripheral innervation slightly complex. And so if you think about the autonomic innervation, you heard about earlier that this comes from the thoracolumbar outflow. And so specifically the innervation, the efferent autonomic innervation, which leaves the spinal cord as at T11 to L1 spinal cord segments. And this is your sympathetic innervation. And and if you've recently learned about neuroanatomy, you'll remember that there's generally a short preganglionic segment, but then you have a long postganglionic segment that then travels to the superior hypogastric plexus. And these are the synapse would have happened. The ganglion sits very close to the spine and the spinal cord. Now, from the S234, you heard about the efferent parasympathetic innervation, which is illustrated in green. And this you have the neurons that sit in the sacral spinal cord, and their projections or axons they leave, and these are long preganglionic fibers that travel quite a way into the pelvis. You have the pelvic plexus, and eventually these fibers reach near the bladder where the ganglion sit. And then you have the ganglion, the synapse occurring, and you have a postganglionic segment that then innervates the structures in the bladder that need to be innervated. So that's the autonomic innervation. So once again, the sympathetic innervation from T11 to L1, and the parasympathetic innervation from S234. Now you also have the somatic innervation from the same segments, but from a different group of neurons at the spinal cord, which the axons of which travel through the pudendal nerve, and they innervate the structures that are under voluntary control, which are the somatic innervation. This is particularly the pelvic floor muscles and the external urethral sphincter. Now, when these axons reach when the nerve fibers reach the lower urinary tract, they end on different receptors. And so you remember the sympathetic fibers that were denoted and illustrated in blue. And so these axons travel through the hypogastric nerves, and they eventually reach the lower urinary tract. So the level of the bladder, they end on beta-3 receptors. And the neurotransmitter released is noradrenaline. Now, the sympathetic fibers also end on receptors in the bladder neck and the internal urethral sphincter. And this is a different receptor. So it's not the beta-3 receptor, but rather it's the alpha-1 receptor that these axons end. But they release the same neurotransmitter. So it's the same neurotransmitter of noradrenaline, but it ends on different receptors. In the lower urinary tract, it's beta-3, and in the bladder neck, it's alpha-1. And this is important to recognize because you modulate these receptors through pharmacology that you'll be hearing about later on in this lecture series. The parasympathetic innervation in green, you have those short postganglionic segments. They end on the muscarinic receptors. And the one that's most functionally relevant to the lower urinary tract is the M3 receptor. You have 5 of them, which are denoted 1 to 5. And it's acetylcholine that is released and that activates these muscarinic receptors. And finally, your somatic innervation, the one that's responsible for voluntary control, the axons, fibers travel to the pudendal nerve, end on the nicotinic receptors at the external urethral sphincter. Now they release acetylcholine, so you have therefore both the parasympathetic and the somatic innervation releasing acetylcholine, so the same neurotransmitter, but what makes them different is the fact that they're working through different receptors. Whereas it's a muscarinic receptor in the bladder, the somatic nerves, the acetylcholine activates the nicotinic receptors. And of course, we need to remember that at the level of the that in the bladder itself, you have the afferent nerve fibers, which will convey the afferent signals. So you have mechanoreceptors that are present that line in the urothelium, and from which you have afferent signaling traveling through the sympathetic and the somatic nerves in particular that convey signals about bladder fullness, but they're also convey signals when the bladder is irritated, which can sometimes lead to the perception of pain from the bladder. Your efferent fibers will innervate essentially the detrusor, particularly the ones that are involved in detrusor contraction, which is your parasympathetic fibers. Now we move from the peripheral innervation to the spinal cord, and we have to think about, once again, storage and voiding. So to maintain storage, you have spinal reflexes. One is from the bladder to the urethra, and this is a procontinence guarding reflex, which sort of protects against your bladder involuntarily emptying itself during the course of this lecture. And also you have a sympathetic mediated detrusor relaxation through the beta-2 receptors that you heard, activating these, resulting in detrusor relaxation, and this thereby ensuring that the bladder is in the storage phase. Now, when your forebrain circuits inform this innervation that it is now a safe and place to void, the bladder has to be emptied. You have spinal cord reflexes that drive the bladder emptying, and this includes a bladder to urethra inhibitory reflex, thereby that urethral muscle is no longer contracted and it's relaxed, which allows the urine to convey. But also you have a bladder to bladder sort of forward feedback excitatory reflex that drives bladder contraction once the detrusor begins to contract. And these all form part of the spinal bulbospinal reflex, which allows higher centers to exert control over voiding. Now, it's not just this peripheral innervation that's important, but it's also about your voluntary control that you've heard about from the start of this lecture. So how full is my bladder? Is this the right time and the right place to void? And these are the questions that require higher control in the forebrain circuits. And so essentially it boils down to this philosophical question, to pee or not to pee. And for that decision to be made by your forebrain, there are 4 conditions that need to be met before switching to the voiding phase. Number 1, is there enough urine in the bladder? Number 2, is voiding socially appropriate? So the voiding must take place at the right time and at the right place. Is voluntary voiding emotionally appropriate? So you wouldn't want to void in a public place, particularly with people that you know, and because you consider the secondary emotions such as embarrassment. And number 4, is it safe to void? In prehistoric times, if you were being chased by a predator, you wouldn't stop to pee at a trunk of a tree and carry on running. So that any threats in the environment need to also be factored to answer this question, whether it's safe to pee or not. Now, how do we answer these questions? The research has been started out in animal studies, in subprimate animals, and then to cats. And now we have several tools to study this in humans. And this is where brain imaging has helped. You will be familiar with some of these imaging techniques, but essentially you can understand gray matter activity by looking at evaluating changes in metabolism in the neurons. This is through techniques such as PET, positron emission tomography, or SPECT studies. Or you can evaluate this by looking at studying the changes in blood flow that occur and levels of oxygen. So if a neuron is active, it'll extract more oxygen from the blood, and based on the change in the signal, that will tell you whether certain regions are active or not. And this includes positron emission tomography, or PET, which also does blood flow as well, but also fMRI, a functional MRI, or NIRS, or near infrared spectroscopy. Or you can evaluate the changes in electrical magnetic signals from the brain using EEG or MEG, which is magnetoencephalography, or evoke potential studies. And these are the different images that you get. Basically, what you're seeing here are statistical maps where color coding is given, and it tells you about where there are significant patterns of activation that occur. So what happens in health? So this is a small study from a group in Pittsburgh, led by the late Derek Griffiths, at n equal to 6 of healthy subjects who are in a scanner. The bladder is filled. They have good bladder control, and with small volumes that are infused and reporting a mild sensation that the bladder is becoming full, you consistently see certain regions that activate. This includes the insula, and the anterior cingulate cortex, and also the periaqueductal gray. Now, when these patients have when their bladders are infused and they have a full bladder, and they have a large bladder volume, and it's not just a mild sensation, but a strong desire to void, what you find is that the pattern changes, and they develop more regions of activation. You can see that the areas of activation increase, particularly in the anterior cingulate cortex, but also the insula as well. Now, these are healthy subjects, but what about in people who have poor bladder control? So they have a condition called urinary incontinence from an overactive bladder, where urodynamics has demonstrated they have detrusor overactivity, and they report a symptom of urinary urgency. When you infuse this group of individuals with saline and small volumes, what you find is quite a weak signal, and it's a bit patchy. So there are bits of the anterior cingulate gyrus here. You have the insula, which is showing activation, but it's certainly not as pronounced as we saw in healthy subjects, which you can see as a comparison on the left. Now, in this group, when they have a full bladder, what you find is actually there's an exaggerated response compared to the weaker response that you see on the left. On the right, you can see many areas of activation in relation to the anterior cingulate cortex and the insula and the pontine micturition center that's there. And so what these studies have shown is that there are key forebrain regions, and there's a consistent pattern of neuronal activity that includes the anterior cingulate cortex, which those of you who have done neuroanatomy will also recognize as a region of the brain that's involved in your emotional response and part of the limbic circuit. The insula, which you will also have learned, is a region that's involved in interoception, involved in the perception of visceral sensations. And in fact, it is a key part of your afferent signaling pathway, so that you perceive your perception pathway. The medial prefrontal cortex, which is involved in decision making, and the parahippocampal complex. And the correlation between these signals provides information about the interconnection between these regions. And based upon this, a working model has evolved that which involves these key neuronal networks. And what we know is that the brainstem and the spinal connections, they form this spinal bulbo spinal reflex, which is involved in sort of bladder filling and bladder emptying. However, those forebrain regions are involved in actually modulating that spinal bulbo spinal reflex, so that you have a storage phase during which time you maintain continence, and a voiding phase when you can safely and appropriately empty the contents of the bladder. And these regions have been organized in circuits, and I won't go into details, particularly because it is quite complex, the field, but essentially you have a circuit 1 that's involved in the conscious perception of bladder fullness, that involves regions such as the thalamus, the insula, the lateral, and the medial prefrontal cortex. Now, the medial prefrontal cortex is something also that you may come across in other regions of the neurosciences, because it is a key region involved in decision making. So to pee or not to pee, to go out on a date or not to go out on a date. That decision-making process is involving this region of the prefrontal cortex. And then when there's a strong urge or perception of urgency, you have additional areas such as the supplemental motor area and the anterior cingulate cortex involved. Now, the supplemental motor area is also very close to the regions of the cortex that are involved in pelvic floor contraction. So you can imagine that if you're urgent and desperate to pee, but are really loving this lecture and don't want to get up and go, what you do is you start squeezing your pelvic floor muscles to prevent yourself from leaking. And then you have the parahippocampal cortex that you can see there. I'll skip this slide to just to move on, just for the want of time. But just to highlight that, when there's small bladder volume filling, so you're not feeling the urge to pee, that these circuits are still active. And circuit 3, which involves the parahippocampal cortex, is actually involved in unconscious suppression of the voiding reflex, which maintains that you are continent. As your bladder is filling and the greater volumes, there's more insular activity, there's a greater perception of bladder fullness, and additional continence mechanisms are involved, and you get activation of the anterior cingulate cortex, the supplementary motor area, a deactivation of the medial prefrontal cortex. But all of these circuits have the same aim of inhibiting that voiding reflex, so inhibiting that bulbospinal reflex to maintain continence. And this is through a region of the brainstem that we call the periaqueductal gray. So as you maintain continence now, what your mechanoreceptors are sending signals up the spinal cord, and these 4 brain circuits are maintaining continence. But how does it do that? So one is through this region called the periaqueductal gray that I mentioned to you, and this inhibits the pons, that switch that I mentioned to you earlier. It maintains the switch in the storage phase, and this is through the pontine micturition center. Thereby, your parasympathetic activity that you heard about earlier ensures detrusor relaxation, and then regions in the spinal cord that are involved in sphincteric control are contracting and thereby preventing leakage. In addition, the sympathetic system is activated. Now, this bypasses the periaqueductal gray and goes directly to the spinal cord, and by activating the sympathetic outflow will suppress the detrusor activity, but also activate your urethral sphincter and bladder neck, thereby maintaining continence. There's yet a third mechanism by which your nervous system maintains continence, and this is through a different region called the hypothalamus. Now, this is a check mechanism, and there's a monosynaptic projection from the hypothalamus onto the pontine micturition center, and this sort of, once again, is an additional layer of protection against incontinence, and then these mechanisms are what promote continence and health. I won't go into detail about networks of the brain, but just those of you who are interested in neurology, and because you're medical students, just to tell you that these circuits you've heard about the bladder, they fit into the larger networks of the brain, and you have a resting state network, which we call the default mode network, which is essentially you daydreaming. So when you daydream, look out the window and you start thinking, essentially you're activating your default mode network, and it's sort of a stage of wakeful rest. And what we know in this network is that these same regions, the prefrontal cortex, the parahippocampal gyrus, are involved in that state, and they're also there to maintain continence as well. Now, there's also a network called the salience network. So say you're daydreaming and there's a fancy car that drives by, or there's someone else that you see, and you therefore there's a stimulus that draws your attention, or it could be the urge to pee. And so there could be a stimulus that draws your attention. That's called the salient stimulus. And the network that becomes activated then is called the salience network. This involves the circuit 2 in particular, and hence, once again, a mechanism of maintaining continence. But once again, they all suppress the voiding reflex to the periaqueductal gray. So something about this region, the midbrain, you may have not heard of this structure, but it is so, so important in homeostasis. It plays a critical role for maintaining not only the homeostasis of the lower urinary tract, but also bowel and sexual functions. And it's a region of the brain stem that sits somewhere here that is involved in the convergence of several important pathways. The region receives afferent signals from the spinal cord as part of the spinal bulbospinous spinal network, but receives descending signals from the forebrain. So you can see it's sort of a midway point between all the signals related to the lower urinary tract. And so the way to think about the periaqueductal gray is like air traffic controller. So say if you're a passenger who's on a flight, a plane that's about to take off, you're not aware of all the work that's going on to get that plane off the ground. But essentially, it's the air traffic control that's involved in that. And this is sort of similar to your PAG. And so there's a takeoff clearance, which I think in the analogy would be really micturition, and really that, that decision to pee has to come from this air traffic controller. But then you have a very busy departure schedule because it's not just a signal from the mechanoreceptors, but also you have from the bowel, the sexual organs, which all want to release their contents, perhaps even simultaneously. And it's the role of the PAG to then to suppress the signals and to decide which one is the most appropriate. But then the air traffic control has to consider so many other factors, the wind speed, runway availability, weather conditions, airspace congestion, and the safety of taking off. And before that decision is made, and this is sort of looking at the environment, the safety, it's an appropriate time, is an appropriate place to pee. And of course, it's the multiple aircrafts that have to take off, not just a passenger plane, but you have military aircraft, you have helicopters, all of which have to take off, and we can't let them all go at once. There has to be a suppression of the bowels when you pee, for example. There has to be a suppression of the bladder when you want to open your bowels, and likewise, all the other visceral systems have to be regulated accordingly. The last region I'd like to take you through is really that you've heard about already, is what happens in the pons, or the Pontines Micturition Center. So this is a picture of Barrington, who worked just a mile away from where I practice at University College London, and actually in the early 20th century performed a series of elegant experiments where he lesioned the cat at different regions of the brainstem to see the impact on micturition, and observed that when sort of sectioning above a certain level of the pons, that actually the cat was unable to initiate urination, and realized that there was a region in the brainstem that was involved in micturition. This region is now called the Pontine Micturition Center, or the M region, of the Barrington's nucleus. And this was subsequently shown in other studies, and Gert Holstiger from the Netherlands had performed similar experiments more recently. And Bertel Bloch, who was working with Gert Holstiger at the time, but also independently has now developed his own imaging unit, actually then demonstrated in PET studies. So this is an image from positron emission tomography, or PET, but where they demonstrated actually in the few healthy subjects that could actually pee inside a scanner, that a region that would be similar to the region what you'd expect for the Pontine Micturition Center in the dorsolateral pons was actually activated in this group. And hence we therefore were able to conclude that there's a similar center in humans that's involved in activating the voiding reflex. So what happens is that you have all this barrage of afferent signals coming from the mechanoreceptors, and if the activation goes beyond a certain set level, then the switching action is triggered from storage to voiding. And when the switch in the periaqueductal gray is triggered, the PMC becomes activated. This sets off a chain of events that initiates micturition, and these efferent descending signals travel to the spinal cord. They activate those parasympathetic nuclei that you heard about earlier, and the parasympathetic efferent signals travel to the detrusor, and they activate the bladder muscle. and the bladder empties. So essentially, to summarize all that, you have afferent signaling that I mentioned to you earlier. The first point of contact is the periaqueductal gray. This involves different regions such as the insula, the prefrontal cortex, the orbital prefrontal cortex, and you have a decision maker, the medial prefrontal cortex, which actually inhibits the PAG and the PMC, and thereby during this lecture, our bladders are all remaining in the storage phase. Now, during that 1% of the time when there's a switch from the voiding phase, rather than inhibitory signals from the prefrontal cortex, you have facilitatory signals that activate the PAG, thereby activating the pontine micturition center, leading to efferent signaling, which thereby allows for bladder emptying. So if you were to take a step back and just want to take home some very, very broad take-home messages, the thing to remember is the most difficult thing to remember is the peripheral nerves. But remember, all they play is a role is in relay of signals. The real work is happening in the neuraxis. The spinal cord, we understand very little, but essentially what it does is it amplifies the descending signals traveling down to your sacral micturition center and amplifies the afferent signals that are traveling up to the brainstem. The brainstem, all it's done is it just coordinates reflexes, but it's your cerebral cortex and the different forebrain structures that are involved in that determination of the appropriateness and the safety of emptying your bladder. So in summary, you have a storage phase during which time the sympathetic system is essentially activated and the efferent signals come out from the thoracolumbar outflow of T11 to L1. Your parasympathetic system, which is really further down in the sacral spinal cord, is inhibited, thereby allowing the detrusor muscle to relax and to contain urine. And also from the same sacral segment, but from a different region of the sacral spinal cord, you have the activation of your voluntary system, the pudendal nerve, which once again results in contraction of the external urethral sphincter. So therefore, you maintain a low pressure system because the bladder is passively relaxing, and you maintain continence because the bladder neck, the internal sphincter, and the external urethral sphincter are all activated to prevent you from leaking urine. Now, the converse happens during the voiding phase. At this point, the sympathetic system is now inhibited, and therefore that relaxation of the bladder is no longer there. And also, you may recall the sympathetic innervation to the internal sphincter in the bladder neck, which is no longer activated, and therefore there's a relaxation there. The parasympathetic system is activated, and thereby resulting in detrusor contraction. The pudendal nerve is inhibited. This external sphincter is no longer contracting because of that the facilitator signals from the spinal cord is no longer there, and thereby allowing for a bladder, a lower urinary tract, where the detrusor muscle is actively contracting and eliminating the urine out. This is driven by the parasympathetic activity, and the urethra is open, the sphincter at the level of the internal and the external sphincter, allowing for the urine to pass. So I will now end on my last slide, which will feed into Professor Mandersbacher's lecture for next week, essentially what happens in disease. Now that you've understood the distribution of the nerve of the lower urinary tract control in health, you will appreciate the key role that the brainstem plays in the regulation of lower urinary tract functions, and particularly with the pons. From a neurourological perspective, we view neurological disorders in terms of those that are suprapontine and those that are infrapontine. Now, you will be you will recognize these neurological conditions. So conditions that affect which are suprapontine. So essentially, your upper brainstem and your subcortical white matter and cortical damage. So stroke, so that could be a vascular cause. You can have neurodegeneration, such as Parkinson's disease. You can have neoplasm, such as a brain tumor. You can have trauma, head injury, resulting in traumatic brain injury, which damages the forebrain circuits. And you can have dementias from a variety of causes, be it neurodegeneration such as Alzheimer's, be it trauma, be it from vitamin deficiency, but you have so many different causes, be it vascular, for example. And then conditions that affect infrapontine. And here we make the distinction between those that are affecting the sacral spinal cord, which is where you have a micturition center sitting, with those that affect suprasacrally, the majority of your spinal cord. So essentially your myelopathies, your spinal cord conditions, you can have multiple sclerosis that can affect the spinal cord injury following trauma, or a neoplasm of the spinal cord. And you can have conditions that affect the spinal cord or further cartilage. So, for example, your sacral spinal cord can be damaged by multiple sclerosis. It could be injured following an infarct affecting the conus medullaris. You have conditions affecting your sacral nerve roots that come out. We call this as the cauda equina. So, for example, you can have a disc prolapse that damages the cauda equina, the sacral roots. You can have a tumor, or it could be further distally. So it could be that perhaps the patient has had a radical surgery in the pelvis, maybe because of cancer, and what we call a radical excentration. And part of removing all the neoplasm means that the small nerve fibers that you heard about, the pelvic plexus, the hypogastric nerve, may need to be removed as well. Or you can have what's called a small fiber neuropathy. So when the small nerve fibers, which are the ones that innervate your autonomic nervous system, get damaged, you get autonomic neuropathy. You get problems with your cardiovascular control, you get problems with your pupils, you get problems with sweating control, but also you get problems with bladder, bowel, and sexual dysfunction. Now, the commonest cause of a small fiber neuropathy that you will come across in your practice is diabetes mellitus, but if you are interested in neurology, you will come across some of the more unusual causes, such as amyloidosis, and vasculitis that can affect the small nerve fibers, or toxins, for example. Now, based upon that level of localization, what we know is that there are certain patterns of lower urinary tract dysfunction. So a patient who has a suprapontine injury, what we know is the connections between the pontine micturition center and the sacral micturition center are intact. So therefore, the two regions are talking to one another in health, and all we have is a problem with that inhibitory control from the higher centers, the forebrain circuits we heard about earlier. What happens is that suppressed bladder no longer becomes suppressed. It gets a life of its own, and you have an uninhibited detrusor. And so patients present with urinary storage symptoms, and urodynamics will have detrusor overactivity, and you'll be hearing about this in the next lecture. Now, they have an efficient voiding because these two centers are talking to one another. So when you will the bladder to empty because of your volitional control, the detrusor muscle is contracting, the sphincter muscles are relaxing, and there is an efficient emptying. And so you empty the bladder well. And if you scan the bladder afterwards, so you put a catheter afterwards, insert a catheter into the bladder afterwards, you will find that the post-void residual volume, or the PVR, is low, because of an efficient bladder emptying. Now contrast that to a spinal cord lesion. So here what happens is that there's now a disconnect between the pontine and the sacral segments. And so because of that, what happens is that there's no longer that efficient emptying of the bladder. When the detrusor muscle is contracting and trying to empty, the sphincter muscle is not relaxing. And you'll be hearing about this term called detrusor sphincter dyssynergy in the next lecture. But as a result of an inefficient voiding, the post-void residual volume, the volume left behind in the bladder after emptying, is usually elevated. The patients will tell you about storage symptoms and voiding symptoms. And what you hear about in the next lecture is that the overactivity here is not from a loss of inhibition that occurs from a suprapontine lesion, but rather because of a new micturition reflex that drives the overactivity. and driven by what we call C fibers that you'd be hearing about. And what happens with the sacral and infrasacral lesion essentially is the last mile is injured. So those signals, the fibers that are supposed to relay the signals are no longer effective. And what you have essentially, therefore, is a flaccid bag of urine. And have urinary retention. Predominantly, the patient has avoiding symptoms, and often what you find is an acontractile detrusor. So on that note, I will conclude to say that that this is this is not an easy topic, but if you get a hang of what happens in health, when you hear what happens in neurological disease in the next lecture, it'll make a lot of sense. And when you understand both, then when it comes to the third lecture about investigations, you will understand, well, what sort of dysfunction that is there. And then you'll think about, oh, that's because there's a lesion at this particular region, the neuraxis. And then when it comes to lecture 5, you will realize, why are we giving medications that work at the level of the muscarinic receptor or the beta 2 receptor or the alpha 1 receptor? Because you will understand their role in health. But what this tells you is that the peripheral innervation of the lower urinary tract is organized across the central and peripheral nervous system, and it's organized across not only the autonomic and the somatic nervous system. When we talk about the central neural control of the bladder, that what we know from experiments in humans and in subprimate animals, that there are consistent patterns in neuronal activity that involve the brainstem and the forebrain, which are involved in the neural control, and that these central circuits can be organized into neural networks that regulate the lower urinary tract and health. I hope I've been able to introduce you to the concept that when we use the term neurogenic bladder, it is very much a non-specific term. And that it captures a lot of things. So we try to avoid this term because it really doesn't convey a lot, because I hope I've been able to convince you that one size does not fit all. And a neurogenic bladder following a suprapontine lesion is different from that affects a spinal cord lesion. And so I think I will end on that note, and I believe there may be a few minutes for questions. And I think one of the key bits about these sort of sessions is that we would like to encourage questions. One, it's learning for us so that we know what we've done right and what we want to improve, but also to help reinforce the learning that you have during these lectures.
Thank you so much, Professor Jalesh. It was very insightful lecture. I learned so much from it. It was very insightful and great lecture. So I think some questions are there. So, okay.
So yeah, so is it Eka? Is it?
Yeah, Adit, Eka, yeah.
Okay.
Yeah.
Okay. Thanks for your explanation. It's mentioned that prefrontal cortex or the brain is the main regulatory of this LUTS defect, right? So we all know that some of psychiatry drugs like sertraline or let's say a stabilizer like valproate and natrium, it's act on the cortex, specifically in occupancy. So if our patient consuming some of neuropsychiatric drug like sertraline or natrium valproate, is there any correlation with their UTS function? Maybe it's kind of make it overactivity or other activity, or is there any correlation of it? Thank you.
Thank you for that question. So there was some disturbance in the background, but if I heard the correction, the question is really around the interface between neuropsychiatry and lower urinary tract symptoms in health and disease. And and I can go straight to the question about medications. So yes, that these medications clearly do affect lower urinary tract symptoms. I don't know if we have any psychiatrists in the room, but essentially it's well known in psychiatry practice that clozapine causes urinary incontinence. And this is something I've observed by psychiatrists for years. It's also been observed in our practice, in many practices, that drugs like olanzapine, your SDAs, they can cause voiding dysfunction, and we do come across patients who go into urinary retention. Now the mechanisms are we don't fully understand, just because we don't understand these medications well. Something important to recognize that particularly the older neuroleptics, they do have an anticholinergic property. And so, because of that, they can they can suppress the muscarinic receptors and thereby lead to retention. Now, you mentioned the SSRIs, which are quite an interesting group of drugs. So these, for those of you who are not familiar, are selective serotonin reuptake inhibitors, and essentially they boost the serotonin levels. Now, because of want of time, I didn't mention the serotonergic system, but you have serotonergic neurons in the dorsal median raphe, the brainstem, which directly project to your parasympathetic neurons and to your ONF nucleus. And so these medications can alter bladder function. So one example of that is duloxetine, which is a medication that is used for pain, but also for depression. But in the urology world, we use this for stress incontinence, and we don't fully understand the mechanism. But what we do know is that there is likely to be serotonergic activation. Activation of certain serotonergic subtypes, particularly in relation to the ONF nucleus, which is supposed to improve the tone of your voluntary external urethral sphincter in this group. Other serotonergic subtypes, receptor subtypes, can suppress the output from the parasympathetic nucleus, and it's been shown that these medications also can help with the overactive bladder. So it's quite complex, but you're right, these medications can modulate LUT's functions. Abhinav, there's another one. I'm afraid that name is in Cyrillic script,
Yeah,
and
it is Ahalya. Ahalya.
Ahalya. Yeah. Do you want to unmute yourself?
Good evening, sir. Good evening, sir. I am Ahalya. My question is that what happens at the neural level when someone holds their urine for too long? Does it affect the long-term control?
So I think we can break that question down. So yes, so if you hold for long periods of time, essentially there's a reason for that. Either it might be that it's inconvenient. I mean, for example, young girls in school will hold their bladder the whole day, and then pee when they get home. Or there may be a threat. You may not have a toilet nearby, it may be unclean, or you might not feel safe to pee just because of the environment. Or it might be a difficult work schedule. But essentially what happens here is that you're activating you're inhibiting your spinal bulbous spinous reflex, your voiding reflex, and thereby promoting it. Now, long-term suppression of the voiding reflex does not affect the central nervous system at all. However, it does affect the bladder, and there can be morphological changes that happen in the bladder when chronically the bladder is distended and over-distended. And in fact, many times patients who present to us in urinary retention in adulthood will give us a history that during childhood or adolescence or early adulthood that they would hold their bladder for long lengths of time. And we think that there is probably changes occurring structurally in the bladder wall, perhaps a thinning of the muscle or inhibition of the bladder muscle activity, but perhaps even fibroelastic changes that occur with chronic, with holding the bladder for whole. I think one important message is not to hold your bladder for long lengths of time. It can cause damage later on. The other thing that we've noticed during the pandemic is that, and following the pandemic, is that people sit for longer lengths of time. And when they sit, what happens is that the change in biomechanics is that they're contracting their pelvic floor muscles. And what we're seeing now in our neurourology clinics are patients with very tight pelvic floors. And this can also, of course, prevent voiding and leading to aberrant voiding patterns.
So thank you, sir. I appreciate your explanation.
Thank you.
Yeah, more questions, Professor Jalesh.
Yeah.
Could you take? So Emma.
Yeah.
Emma.
Oh, yes. Okay.
Good evening, good afternoon, Professor, and thank you for your lecture. My question is pertaining to bedwetting, especially when found in the cases where we can see in teens or young adults or even adults that seem healthy, but they seem to have nightly episodes of bedwetting. How can that be medically explained in healthy or seemingly healthy teens and adults or young adults?
So I'll introduce a term called nocturnal enuresis that I think will be introduced next week or the week after, which essentially is incontinence occurring in your sleep. Now, there is an age during CNS maturation where it is considered as normal to have bedwetting, and but beyond that phase, if there is bedwetting, that is never normal. So if there is an adolescent or an adult who is reporting bedwetting, it needs to be investigated. You will see if it's a primary nocturnal enuresis that started from that where the child or the adult never became dry by night, or if it's secondary where they were dry by night and then began to experience bedwetting. But you would want to investigate from a neurological perspective, looking at conditions such as, say, spinal dysraphism that can present in late teens and early in their 20s with bedwetting and bladder problems. You would think about urological causes that can cause this as well. You would want to inquire about psychological problems, about a history of trauma, physical trauma, bullying, sexual trauma. You'd want to have a battery of tests or questions that you want to ask, investigate, but it is not normal for bedwetting to occur at that stage, really, and they should be investigated for some pathological process. What I will say as a rule of thumb is that if you have a patient with a neurological disease who is bedwetting, nocturnal enuresis, you need to check if the patient's retaining urine. That is perhaps a very though it's non-specific, it's a very useful symptom that we go by in clinic. If they tell us nocturnal enuresis, we always check their bladder scan to see if they're retaining urine.
All right, thank you.
What's the next?
There are some questions.
Yeah.
Niharika. Niharika?
Yes, I have a question. You told us that Pontine Micturition Center, I don't know if I remember correctly, but does it provide us voluntary control over micturition? And what exactly is its role if we compare it to the cerebral cortex? Because it also provides voluntary control over micturition. I want to differentiate between the two, and also, like, I have another question. In the micturition center, you told us that it is kind of a switch that allows us to void, like a switch between storage and voiding. What actually triggers this switch that, like, allows us to void? Like, what is the switch to this process? What triggers us? And the difference between the micturition center and the cerebral cortex.
Okay, so think about like a child and a parent. You have a child who really would like to do things, but is really obedient and will gain the permission of the parent before it does that. Now, with that analogy in mind, the Pontine Micturition Center is sort of like the child, right? It is the one that wants to do something like, for example, activating micturition, but only with the permission of the parent, which is your forebrain circuits. So they work in tandem, so though the pathway down to the sacral micturition centers from the pons, without facilitatory signals from these forebrain circuits, that will never happen in health because essentially the Pontine Micturition Center remains suppressed. Remember, the brainstem is involved in vegetative functions: sleep, consciousness, breathing, heart rate control, blood pressure control, bladder, bowel, sexual functions, all the vegetative functions, but for many of these functions, really it's the cortex that determines when you pee or when you poo, when you have sex. All that is determined by the cortex, and so that's really the role of the brainstem. So your other question was about the Pontine Micturition Center, I think, and so really the forebrain circuit work through the periaqueductal gray, and then the pontine micturition center to then determine the switch between storage and voiding. So if you have inhibition from the periaqueductal gray, which is because of inhibition from your forebrain circuits, you will be in the storage phase. When it is deemed appropriate in time and place to void, and you get excitatory facilitatory signals from the PAG and the forebrain circuits, then the switch occurs and the PMC, the pons, will send signals down and thereby activate the reflex of voiding.
Okay, so if the PMC is injured somehow, the person won't be like voluntarily able to void. Yeah.
That is correct. So that is correct. So in patients who have a tumor, like a brainstem glioma, for example, or if the patient has developed a stroke, what we call a brainstem stroke, what we often find is that if they survive a brainstem injury, is that they are in retention, and that's really because they are unable to initiate voiding.
Voiding. But there will be involuntary voiding, not just like there won't be voluntarily voiding, but still involuntarily voiding would be present.
Yeah, so if it's a pontine lesion, what happens is that they are in urinary retention. And if we miss the urinary retention, what happens, you get an overflow incontinence. And so the patient will be telling you about incontinence and leaking, which is occurring involuntarily, but it is secondary to being in urinary retention.
Okay.
There are more questions,
Yeah.
Professor.
Yeah.
Mohammed Hanif. Hanif? Mr. Hanif?
Yeah, Professor, it's a good lecture. I've learned a lot from it. Yesterday, I came across a term like the brain, gut, and the bladder axis. I was wondering what could be the possible role of gut in this crosstalk between the brain and the bladder, and with evolving technologies, is there something like the possible role of gut and gut health in terms of improving the LUT symptoms of the we can like what is the role of gut in this crosstalk between the bladder and the brain?
Yeah, that's a fascinating question with the brain-gut axis, and we know quite a lot of, we know some more about this than say a few years ago, and how we modulate this through probiotics and prebiotics, etc. Now, how this brain-gut axis directly can impact your lower urinary tract control is something that's been poorly researched. What we do know, however, is that the bowel and the bladder have separate switching circuits. Basically, you've heard of switching circuit today between storage and voiding, but there's a similar switching circuit for the lower bowel as well. Now, though they're separate, they are closely linked to one another, and so there is if there's an injury to the neuraxis, what you will often find is that both these switching circuits become injured together, and you get bowel and bladder problems. And one of the problems that patients would tell us is that before they were able to suppress one when they opened the other. So they were able to empty their bladder but suppress bowel movements, and vice versa. And that's often a complaint that patients will report when they've developed an injury, either at the level of the spinal cord or the peripheral nerves that relay from the brainstem, from the spinal cord to the pelvic viscera.
Thank you. It was very insightful.
Thank you.
Next question is from Jyoti. Jyoti?
Hello. Hello, Professor. My question is about stress-induced urine incontinence. Like, stress is one of the factors for incontinence. So I wanted to know that what should we do so that acute and chronic stress doesn't cause severe losses in the patient, and the incontinence doesn't affect their life normally, because medications we can't give for every little stress or any chronic stress. So I was wondering, apart from medications, what else can be used?
Okay, so when you say stress, do you mean physical stress or do you mean mental stress?
Yes, psychological
Sorry.
and physiological.
Okay, right. So when we use the term stress incontinence, well, though it is probably not the right term, we were alluding to physical stress, so effort and exertion that results in incontinence, and so that stress incontinence is different from incontinence that occurs, for mental stress. What we know is that regions in the forebrain that are involved in the emotional control, so specifically the limbic circuit, they overlap with these forebrain circuits that control bladder control. You heard about the cingulate cortex in particular. So when there is an emotional state that's related to anxiety and other affective symptoms, we know that these patients often experience overactive bladder symptoms. And we know that when the anxiety level drops, is that their urgency and frequency often drops as well. And we think this is really because of the level of the interaction occurring in regions such as the anterior cingulate cortex. Now, to address your symptom, to address your question, what can be done? So we know that cognitive behavioral therapy, we know that relaxation techniques, we know that meditation, and we know that anxiolytic drugs will help not only with the primary psychological comorbidity of anxiety, but by alleviating the anxiety can also help with urgency frequency. And in fact, when we initiate conservative treatment for urgency incontinence, one of the first steps is about deep breathing exercises and mindfulness, where you're in the present at the time, rather than having a mind that's sort of diverted. And this all involved in stress alleviation, mental stress alleviation, which can also help with bladder control. What we find often that people who have urgency incontinence is they become anxious about urge because they might have become incontinent. So imagine if one of you in this room were becoming incontinent, it's probably the most dreadful experience that you can ever have, particularly if you were with friends or family. What will you do is every point that you have an opportunity, you will go and pee. And so you will plan your toilet, your habits, but you will pee quite often. So one of the measures that we initiate is to actually break that habit through bladder retraining, but also to relieve that anxiety related to urgency to try to unpick that symptom. And when we address the underlying anxiety around incontinence and we initiate measures such as antimuscarinics or pelvic floor training and demonstrate the patient can hold for longer lengths of time, then you thereby reduce the anxiety. So you can see that it's a bi-directional approach when you try to address mental stress and lower urinary tract symptoms.
Thank you, sir. And like, why is it like this that some people under stress experience incontinence, but some people under stress don't even feel the urge? Like they even after the stressful condition is over, they don't even have the urge. They feel like, no, I can't even go to washroom now.
Well, that's a very complex question. The short answer is we don't know. But there is something called resilience that is there, and it's difficult to sort of define physically what resilience is. But from a mental health perspective, essentially, with resilience, some people are able to accept stresses and deal with it different from other people. I mean, for example, many of you in this room who are in the Ukraine now probably have a much greater resilience than, say, someone in Western Europe, for example, where they've not lived in a war situation, and our environment often determines the resilience. And this is probably wired in from birth to an extent, but also acquired through experiences like these. Now, some individuals, what happens is they go through a traumatic experience, what happens is they develop a condition called post-traumatic stress disorder, PTSD, and what happens is that basically there is a sympathetic overactivity that's happening. There's a hypervigilant state. Now, hypervigilance is not only in relation to the stimuli that cause the trauma, but as a protective mechanism, what happens is the mind essentially becomes hypervigilant to any stimuli, and this could be external stimuli. So even the sound of something that would not have been related to trauma itself can trigger off that sympathetic activity. But it could be internal stimuli as well, for example, the need to pee. And in that hypervigilant state, you become aware of your bladder much sooner than what should you'd expect, and therefore it activates this hypervigilance network in the brain, and you act on this, not you in particular, but the individual acts on this by emptying their bladder, for example. And so, as part of therapy for PTSD, this is sort of one has to recognize this hypervigilant state and see how that can be addressed. Much more easier said than done. And what we do in our clinic in particular, we do get quite a few individuals who have gone through trauma, particularly sexual trauma in childhood and childhood sexual abuse, and they come to us with all sorts of bladder, bowel, and sexual problems. And we have a psychologist who works in our department, and they are playing a key role before we even start the first treatment for their bladder problem, to try to unpick the problem and to see where their symptoms are coming from. And it's a very complex process that occurs for days, for years. Many of our patients, we keep them in what's called a holding bay, so we don't discharge them from clinic, and so that they feel reassured that they're actually still under a urology or a neurourology service, but we send them away for different sort of assessments and management of psychological comorbidities, of PTSD. They come back to us in a year or 2 years in a much better state to accept their urological treatments. And we do have a few urologists in the room, so who might find this controversial, but from our uroneurology perspective, I think very much bladder problems as a behavioral disorder is the way I see this. And when you think about the overactive bladder, it isn't an organ-specific condition of the bladder alone, but there's a very strong mental and cognitive process that's there. And if you want to treat the patient holistically, you need to consider all the aspects to treat this condition of an overactive bladder.
Thank you very much. It was a new perspective for me.
Thank you. And so I think we've got 2 more questions.
Yeah, Professor Ruth also agreed with about this explanation. So next question is from Tejpal. Tejpal.
Good afternoon, sir.
Good afternoon.
My question is there any new research or technology that help us to better understanding or modulate bladder control neurology?
So the question is about technologies to modulate neural control, neural activity, is that correct?
Yeah. Yeah.
So there are, and I think you'll be hearing about this in lecture 4, about treatments, and you'll be hearing about how we've used electricity actually to modulate these circuits. So there's quite a bit of research, but essentially what we know is that by modulating the reflex, this micturition reflex at the level of the sacral cord, level of the brainstem, and at the level of the forebrain, you are able to alter functions of the lower urinary tract. So, and here you need to understand that there are structural urological disorders such as a stricture, an enlarged prostate, a prolapse, which cannot be managed by electrically modulating. But then you have another set of conditions which are functional bladder disturbances. You heard about the overactive bladder, sometimes with chronic idiopathic urinary retention, many of your neurological bladder disorders, where because there's not a loss of structure, not an impairment of structure, but function, you can alter these neural circuits to make right the bladder. A classic example is the overactive bladder that you've been hearing this afternoon, where there's urgency, frequency, incontinence. And what we know is that if you introduce electricity at the level of the sacral roots, or at the level of the tibial nerve, or at the level of the dorsogenital nerve, and this nerve stimulation will lead to a modulation of these reflexes, their urgency, frequency, incontinence gets better. And examples of these are sacral neuromodulation, or tibial nerve stimulation, or dorsogenital nerve stimulation. On the other hand, you have a condition of idiopathic urinary retention. We sometimes call this Fowler syndrome. There are different terms that are used, dysfunctional voiding, but essentially There is a functional problem with the retention, and in this cohort of women, where if we modulate the sacral nerves through sacral neuromodulation, in more than 70% of women, they start to pee again. So yes, you can modulate these circuits successively, and it is very much a topical thing in both neurourology and functional urology.
Thank you, sir. Thanks so much.
There is one question, Professor, from chat by Pooja. So what is the role of basal ganglia in bladder control?
Yes, so I didn't touch upon the basal ganglia just because of the want of time, but the basal ganglia, they essentially they connect to different regions of the cortex, and are involved particularly in motor control, for the smooth motor control. Now, their precise role in the neural control of the bladder in health is unclear. But what we do know is that they do play a role, because if you have a basal ganglia injury, there are problems with the bladder. The classical example is Parkinson's disease, where you have a region of the brain called the substantia nigra in the midbrain, and its projections to the basal ganglia, like the striatum, which get affected in this neurodegenerative condition. And very complex, but essentially you have dopaminergic and GABAergic circuits that get affected, which results in an overactive bladder. You have patients who have stroke, and they developed an infarct in the basal ganglia or a bleed in the basal ganglia, who will tell you about urinary retention or about urgency incontinence. And so in those sort of patients, we know the basal ganglia has played a role. But the exact role in health hasn't really well been defined. But you need to think about, when you think about the neural control, think about networks. So rather than regions. So you have these forebrain regions, you have the thalamus, you have the basal ganglia, and these networks talk to one another, and injury to any one part of that network is going to result in bladder dysfunction. It could be at the level of the frontal cortex, it could be the level of the PAG, it could be the level of the cingulate cortex. Whenever there's a lesion affecting any part of the network, there will be bladder dysfunction.
Thank you, Professor. Yeah, Pooja said thank you. So everything is good. So thank you, Professor, for this insightful lecture. I really like it. Myself really like it. So would we take a group photo? Would we?
Yeah.
Okay. So I'm opening. Everyone, please open your camera. I will take the screenshot. Yeah. More people.
So nice to see the
Great.
different faces, and we see that we are kind of global. And I saw a lot of Ukrainian. I only know when I see the language. Very nice. But I know also that they often lack internet connection. But very nice.
Fantastic memory. And I think you had at the peak, I think it was probably around 130. Oh, and we have
135.
135, and we have Helmut. Helmut, do you want to unmute yourself, perhaps? So Helmut Mattersbacher said is the doyen of neurourology. Without which I think the specialty wouldn't be there. So you are really lucky to be hearing him next week. But Helmut, I think you're still mute, Helmut.
Now we see him.
Yeah. Yeah, now we can hear.
Yes, we can hear you now.
Well, I enjoyed your lecture, and I think your charts were excellent, and it's a very good basis for my lecture next week. I thank you very much. I congratulate you.
We will wait to hear from you.
Yes, and it's a lecture you shouldn't miss. And then Ruth is going to be taking it forward in terms of assessment. And then
Glenn is assessment, and I'm treatment.
The treatment, sorry, yes. And then you have cases at the end.
Yes, this cardio. Yes, no, it's very nice to be part of this group.
Okay, have a smile.
And but the questions, your quiz. I mean, don't forget.
Yeah, I will send them. I will send them.
Okay, you send them. Okay.
Brilliant. Okay. And I think on behalf of INUS, I think Christina, Abhinav, I think all of you, I think we need to really congratulate you for the passion that, I think this last 6 months in developing this lecture series has been quite a bit of effort. You've got your day job as medical students, you've got, whatever's flying in the air coming at you, so, despite all the challenges, putting this together, I think it's incredible. And you must be congratulated for that. And I think this is an excellent start. Those of you who are still in, we would encourage you to build your knowledge in neurourology. There's some excellent questions that will come out just to test your knowledge. But the case discussions, I think would be fantastic, because that's where you then bring all this knowledge together and you apply it to the patient.
Okay, we were also very grateful to have a collaboration with you, all the professor, and thank you very much for that. So,
Thank you.
okay,
Thank you.
lastly, have a smile.
Thank you so much, sir, for your wonderful lecture.
Thank you very much, everyone. Thank you.
Great. Okay, thank you so much, Professor. Thank you so much for joining, to all of you. See you next week on Thursday. See you.
Thank you.
Have a good evening.
And thanks for the organization. I think that was excellent. Technique
Oh,
was great. Thanks, Jalesh. Thanks, Abhinav, and thanks, Alice.
Oh, no.
Thank you. Thank you, guys.